Last week, I opened the live stream series with a breaking story. Providence Health Plan, the third largest health insurance carrier in Oregon, announced they were shutting down their entire health insurance operation as of January 1st, 2027. 421,000 members in the state of Oregon. 1 in 10 Oregonians, they needed to find new coverage before the end of the year. Their CEO called it an untenable situation. Rising costs, national insurers consolidating, it created a place where regional nonprofits are just unable to compete. I told you then that Providence exit was the headline. The history was the explanation. Since that first episode, something remarkable has been happening in the background that I need to share with you before we go any further. Because Providence isn't alone on this. Pacific Source is a regional nonprofit health plan based right here in the Pacific Northwest. In the state of Oregon, they have their main office. They started serving the Oregon Health Plan after I retired from Trillium. Here's what has happened to them in just the past 2 years. In 2024, they announced major layoffs and pulled back significantly from Washington State. So they've got some members in Washington, but it's so much smaller than it was at one point. They specifically cited provider consolidation, rising healthcare costs, and difficulty competing profitably. Sound familiar? In September 2025, they notified the state of Oregon that they would not renew their Lane County Coordinated Care Organization contract, or OHP, Medicaid. Roughly 90,000 Oregon Health Plan members were affected. Oregon and Pacific Source could not reach a new agreement, and early in 2026, almost all of those 90,000 members transitioned out and went to Trillium, a company I'm very familiar with. And just last week, Pacific Source announced they are leaving Montana entirely. They're exiting the market there, and that's another 42,000 members affected. Just a few years ago, Pacific Source celebrated Montana, and it was a growth market, is what they said. And that they had their 10th anniversary in 2022, and now they're gone. So let me just put this timeline on the table. 2024, Pacific Source, major Washington pullback. 2025, Pacific Source, Lane County OHP contract abandoned. 2026, they're leaving, Pacific Source is leaving Montana. And then at the end of 2026, starting January 1st, 2027, Providence is no longer going to have a health insurance plan. 421,000 more Oregon members are affected. This is not random. This is not bad luck. This is a pattern. Now here's the part of the story that stopped me cold when I first read it. Those 90,000 Lane County OHP members that Pacific Source couldn't serve anymore, they transferred primarily back to Trillium Community Health Plan. That's the plan that I was the CFO of for 18 years. The organization that went from 30,000 members to over 90,000 members essentially overnight when the ACA started. And that growth almost broke our organization. That put a tremendous stress on it, but it didn't, and we kept going. I'm not saying this to suggest that anyone at Pacific Source did anything wrong. I say it because it illustrates something important. The skills, the reserves, the infrastructure, the relationships, everything we spent years building at Trillium. That wasn't just organizational pride, it was survival. And not every regional plan is able to build that. Excuse me. Pacific Source publicly cited rising medical costs, provider consolidation, and unsustainable healthcare economics. Those are real factors. But from where I sit, having spent 18 years as a CFO inside exactly this model, I'd add something they didn't say publicly. When hospitals consolidate, negotiating leverage shifts. A regional health plan suddenly finds itself across the table from a dominant hospital system that can demand significantly higher reimbursement. And a regional nonprofit doesn't have the scale to absorb that the way a national for-profit can. Regional nonprofits unable to compete, those were Providence's CEO's words just a couple weeks ago. They could have been spoken about any of us. And here is the question nobody is asking loudly enough. How did we get here? This didn't happen because of decisions made last year. It happened because of decisions made 30, 40 years ago about who carries risk, about who controls structure, about what happens when local control of healthcare meets national consolidation. This is exactly what this series explains. Providence's exit is the headline. Pacific Source retreat is the confirmation. The history, starting right here in Lane County in 1977, is the explanation. Which brings me to today. Last week we talked about the little-known organization that quietly ran Lane County Medicaid for decades, how a group of independent physicians in 1977 decided they needed to come together to protect clinical autonomy and local decision-making. Today we're going to go one layer deeper, because once those physicians had their organization, the state still had to make a decision that shaped everything that followed for the next 40 years. Why did Oregon choose to hand Medicaid to insurance companies and physician organizations rather than run it themselves? And were those organizations actually ready for what they were being asked to do? I was inside the answer to that second question for 18 years. Let's get into it. The state's decision. The state faced a fundamental question when the Oregon Health Plan launched. Do we build the machinery ourselves, or do we contract with organizations that already have it? The answer was practical, not ideological. Health plans already had claims processing infrastructure, provider networks, financial reserve management, medical management expertise. Building all of that inside a government agency from scratch, well, that'd be pretty expensive, slow, and likely incompetent. The state provided that point themselves. You see, when they started this plan, the OHP and Medicaid, they wanted to have these health plans help them with it, and that made a lot of sense. But there's always a group of people in every area that don't get along with health plans, and there's always a group of people in every area that health plans don't get along with the members. And so there would be paperwork and petitions and what have you, but eventually roughly 10% of the population ended up staying with the state, where the state had to manage the care. So what happened? The claims were paid slowly. Medical management was essentially non-existent. The infrastructure simply wasn't there. This isn't what we want government to be doing, and they didn't do it well, through no fault of their own. That's just not their strength. The state accidentally ran a natural experiment and lost. This was probably the best decision, and they proved it by showing what the alternative looked like. But were the health plans actually ready? Here's what the article that I wrote that's on Substack doesn't tell you. The state chose health plans and physician organizations because they had more infrastructure than the government. That was true, but more infrastructure than the government, that's a pretty low bar. The honest answer is that many of these organizations, including LIPA, were figuring it out as well. When the contracts were first awarded, the state had lower reserve requirements. So we talk about that in a few weeks when the insurance division gets involved and how much the reserve requirements are needed. Well, this is back in the late 90s, early 2000s, mostly late 90s. The insurance reserves that the state required, they just weren't that high. And it was because a lot of these plans, the smaller plans in these areas that they were working with, didn't have the resources to have the reserves that were needed for a normal health insurance plan. Well, how did they get around this? So there needed to be something that helped to offset the fact that they didn't have these large reserves. At LIPA, it usually happened through one of the major ways was reinsurance. And so what reinsurance is the health plans then, LIPA, for example, that I did, we went to a company, a broker, and we got bids from all these huge reinsurance companies. And then we'd set an attachment point. And so whenever a member had services over a certain amount, the reinsurance carrier would take that risk. Well, if you set that attachment point low enough, you're essentially creating this like an insurance reserve, because you are limiting your risk, if not completely resolving your risk at a certain point. And so it keeps you from going broke, essentially. So when I started with LIPA, we had our reinsurance level at 40,000. So if a member went over 40,000 in medical expenses, that would then go to a reinsurance corporation. Over time, reserves grew and the attachment point could grow. Eventually, LIPA even self-insured themselves. We had enough reserves to do that. We were able to use our own balance sheet. And that saved us just a ton of money. If you can imagine, if you're buying reinsurance and you're having to buy it at this low level, they're able to just charge you an abundance of money to cover these patients. And in fact, where our medical loss ratio, our goal was 85%, the goal of these reinsurance companies was 60, sometimes even 50%. So let's just say in the course of a year, you've paid them $2 million. Their goal is to only pay you back $1 million, and they make $1 million, that 50% medical loss ratio. So being able to self-insure yourself and reset that price was a big advantage for LIPA at the time. Those are the kind of decisions the state couldn't make that we were able to, and that helped to make our plan work well. So when I arrived at LIPA, this is what the managed care operation looked like. They had 4 nurses providing care coordination. 2 had prior health plan experience. 2 came straight from clinical health care and really had no idea. It took them probably about a year to get to where they understood exactly how to work inside of a health insurance plan. And then they had 1 physician medical director who came straight from private practice. Medical director was a great guy. He was a data nerd. Unfortunately, when you're the head of medical management, being a data nerd only gets you so far. You need somebody that's going to help you manage care. And that just wasn't what he wanted to do, and that wasn't his strength. And so that put us put us in a tenuous position at times. Another example of our lack of firepower of our employees. When I started, I was hired as the to be over finance and to be over the contracting department. Well, when I got there, the finance department and contracting department consisted of 1 bookkeeper and 1 assistant. What I was responsible for was obviously the monthly financial statements. I then was also responsible to contract with the state of Oregon for our funding. I was also responsible for contracting with the providers in the hospitals. So there's roughly 200 to 230 different contracts that we had as a health plan at that time. And then on top of that, we provided the physician panel for 4 commercial health plans. And so we negotiated how much these physicians would get paid by all of these health plans. And that was in my in my ball of work that I was supposed to do. It was tough. The day I started, I was quite a bit behind. A few months before I was hired, LIPA brought me on as claims manager because I had done the LIPA contract when I worked at SelectCare. And SelectCare was the original holder of the OHP contract. So they hired me because I had the understanding of how the contracting and how the financial process worked for the OHP in Lane County. Also, my job at Select Care was to negotiate the reinsurance contract for their whole book of business. So LIPA brought me in because I was essentially doing the things, a few of the things they needed already for their company or with their company. I understood their vulnerabilities before I walked in the door. I left Select Care because Providence was acquiring them, and I saw the writing on the wall. LIPA approached me at exactly the right moment. That's the same Providence that purchased Select Care in the mid-90s, and then they pulled out of the OHP plan in the early 2000s and essentially just gave us those members. So I'm telling you this story because this is all just kind of a full circle moment, and it was playing out in real time for me. The layered responsibility structure. LIPA didn't assume full financial risk on day one. It happened in stages. First came the arrangements through Regions Blue Cross Blue Shield and Select Care. LIPA coordinated care and accepted some financial risk, but it was mediated through the insurer. The exposure existed, but it was limited. So this is back in the early 1990s. Then in the late 1990s, LIPA assumed the Regions contract directly. They essentially said, we don't want this anymore. We have 15,000 members. We're not making money with these members. Here, you can just take these 15,000 members. And then in 2000, Providence essentially did the same thing. They said, we're not making money. They went to the state and said, we are pulling out of OHP. The governor of the state of Oregon came to my boss and begged us to take on these members. So then we had 15,000 more members. So we, without paying a dime for these members, we all of a sudden had 30,000 members. Just so you know, when a for-profit company comes in and looks at a nonprofit or looks at a regional plan, how they determine how much they're going to pay for it, one of those is that by how many members this plan has. And then they actually pay money for those members. Well, we were just given 30,000 members, and then when the expansion happened, we grew to 100,000 members. So we never paid for these members. Just a little extra information. So what does full financial risk actually mean? We would get a fixed payment per patient. That's called capitation. We would have to provide all necessary care within that budget. So let's just say we were paid $200 for that patient. Our goal was an 85% medical loss ratio, so we would hope that we would spend $170 per month. We'd get $200 a month from the state for the patient. We would hope that we could keep the cost to $170 per month. And if we did that, if the costs were lower than that, that was just additional profit for the company or profit for the company, and then that was paid out to the providers. But if our costs were higher than that, we just had to absorb it. So preventative care financially really mattered at that point. And you kind of the physicians started to get on board with it. They started to see that if they managed care correctly, they could get some significant bonus checks. So coordination just mattered. Avoiding hospitalizations mattered. Just being the PCPs, having a relationship with their members was really a key, and it helped everybody out financially. The physicians were betting that clinicians given responsibility for both care and cost could make better long-term decisions than administrators at distant insurance companies. Most health plans, they kept these two things completely separate. Well, LIPA, we kind of blurred the lines and we brought them together. We were owned by the people, the physicians, that were managing the care. Sounds like the right business model, really. And then they would try to do whatever was necessary to get their patients healthy and keep them out of the hospital, keep them out of the ER, and minimize the number of times they had to even come see the physician. This was unusual. LIPA was one of the first to do this. And it worked. And so we were able to grow, like I said, the company. We were able to sustain a model that at times did not make sense. And what's happening now is that that model has kind of gotten turned on its ear. So Providence and Pacific Source, they're pulling out because they don't have the physician buy-in quite often. They're not sharing that surplus money with their physicians that they're contracting with. They're not encouraging them to keep the patients out of the hospital in a way that makes sense. They're essentially have gone back to telling the physicians how to do the work. They're making the decisions. The physicians aren't. That's happening at both Pacific Source today and at Providence. And because of it, their margins have compressed. They're not making money. They're not paying out surpluses to the physicians. They're not paying surpluses out to the hospitals because they can no longer get good hospital contracts either, because the hospitals have just grown and grown and their leverage is so strong that the smaller health plans just cannot fight that fight any longer. In Lane County, we sustained it for nearly 40 years, from 1977 through the Centene acquisition in 2015. That didn't happen by accident. It happened because of specific decisions made by specific people at specific moments. Once you accept responsibility for cost at that scale, you cannot stay the same organization. You have to build administrative systems, financial infrastructure, governance structures capable of managing population-level care. You have to change. And that change from a physician association to something that looked a lot more like a health plan is exactly what we're going to talk about more next week. How a coordination network became an operational health plan. What that transformation required and what it cost. With risk comes reward, but first comes the work of building something capable of carrying the risk. I appreciate you joining me today. I hope you'll join me next Tuesday again at 8:30 a.m. Pacific Time. Have a great day.